Good morning or good afternoon, depending where you are, and thank you so much for joining us. My name is Emmy Betts, and I serve as the Deputy Director for the Injury and Violence Prevention Center here at the Colorado Anschutz Medical Campus. Today's presentation is part of our monthly Research to Practice webinar series, where we present topics in injury and violence prevention. And we're thrilled today to be co-hosting with the Multidisciplinary Center on Aging. Before I introduce our speakers, I have a few logistics to share. The first is that we will be recording this and we will send the video link to everyone who's registered. We'll also post the link where you can find past webinars on our website. I'll ask that you please put any questions into the Q&A box at the bottom of your screen. Our presenters have promised me that we will have some time for questions and answers at the end. So please feel free to put those in throughout the talk, and then we will circle back at the end. And then please mark your calendar for our next webinar, which will be March 8th at noon Mountain Time or 2 p.m. Eastern. And it will focus on firearm storage maps, so maps for out-of-home voluntary temporary firearm storage. And so now I am really excited because two really superstars have agreed to present to us today about a really important growing topic. Their title of their talk is The Unexamined Epidemic of Elder Abuse, Ending Gaze Aversion in Medicine. The CU Anschutz Multidisciplinary Center on Aging, along with the Kempe Center here on campus, have developed the second clinical team dedicated to elder abuse victims in the country. The so-called Vulnerable Elder Services Protection and Advocacy Team, or VESPA, at University Hospital and at Denver Health is a dedicated consult service available to evaluate and help support victims of elder abuse and neglect. And today's speakers are going to be talking about this novel clinical approach to elder maltreatment in Colorado, along with implications for research. So first, I am thrilled to introduce Dr. Blumen. Dr. Elizabeth Blumen is just a superstar. She's currently an internal medicine resident, but don't let that fool you. She's in the primary care program at the University of Colorado School of Medicine and the lead consultant for the newly formed VESPA. We're thrilled that she'll be continuing on into a geriatrics fellowship when she finishes residency this spring. Dr. Blumen grew up in Fort Collins, received her bachelor's in biochemistry and molecular biology from the University of Colorado Boulder, and her MPH from Columbia University. She attended the University of Colorado Medical School and has worked in the field of elder justice for over 7 years, in addition to her clinical training. She's really focused primarily in the medical provider's response to physical and sexual elder abuse and neglect. In addition to helping run VESPA, Dr. Blumen also leads the campus-wide Elder Justice Task Force, and she is really just a rock star. Not to, though, disparage Dr. Lindberg, certainly also a rock star. Dr. Dan Lindberg is an associate professor and physician in the Department of Emergency Medicine and Pediatrics at the University of Colorado School of Medicine. His research is dedicated to improving the recognition and care of child, as well as now geriatric physical abuse. He received his BA in biochemical sciences from Harvard and then went to the University of Chicago for his MD. He currently serves as the Vulnerable Elder Services Protection and Advocacy Team's medical director, bringing his long experience in what we've learned from child abuse and clinical teams for recognition of child abuse. And he's a faculty member of our Injury and Violence Prevention Center. So with no further ado, I'm thrilled now to turn it over to our guest speakers. Thank you for presenting today, and thank you to everyone for joining us. And please remember to put questions in the Q&A box.
Great. Thank you so much for having us. I hope you can see my screen. It's not working. Okay, great. So I'm Elizabeth Blumen. Thank you so much for the lovely introduction.
Oh, sorry, Elizabeth, you might want to switch screens because you're on the presenter. We're seeing the notes.
I apologize. There we go. Is that better, Dan?
Yes.
Okay, thank you. So first off, Thank you all for having us. We're very excited to be here. We do not have any relevant financial disclosures, although part of our time in this work is supported through a Victim of Crime Act grant, which we'll talk a little bit about later. So for today, we're going to go through just a little bit of the epidemiology of elder abuse and neglect, talk about the new program that we are developing, and then discuss some of our research goals for this program, because research is really intertwined into our clinical program quite closely, and talk a little bit about a new methodology that we're really excited about bringing to the field of elder maltreatment, which is goal attainment scaling.
As a clinician, my habit is to start most talks with a case to help us focus on what the problem is and explain how VESPA works. Most of the details of this case are taken from VESPA's experience. Some are amalgamations from other cases, and this is obviously a stock photo. But Mr. R is a consult that we saw on VESPA recently. He came to the emergency department after EMS was called to his house because of his altered mental status. According to the EMS, the paramedics, they encountered Mr. R in a bathtub, and they were told that he'd been there for 3 days. They report that the home's walls had feces on them, and that Mr. R was pretty disheveled and covered in feces himself. Mr. R's son, who called the ambulance, wasn't able to provide much more detail in terms of what had been happening to his dad, even though his son lives in the home. The patient had severe metabolic derangements. If he hadn't had care, he probably would have died. But in this case, he was admitted to the ICU and was stabilized medically.
Thank you so much for that, Dan. And I think while it may seem obvious, it's important to talk about, does this case truly represent elder abuse? And our field has struggled to come up with a definition. I think we've landed on one that we all seem to like. But what defines elder abuse versus just other violence or bad things that happen to older adults? And what we have come up with is really that elder abuse happens when there's an expectation of trust within that relationship. So this could be a family member, a romantic partner, a neighbor, or a paid caregiver, which I think is what most people think of when they think of elder abuse. But it has to be someone where there's an expectation of trust that has been violated in the abuse or maltreatment. And so this comes from CDC, was developed about 5 years ago. And then elder abuse in general can come in many different flavors, similar to violence that we see across the life course. And I think what's interesting with older adults is that we see things that are unique, but also have similarities to both child abuse and domestic violence in earlier life. So certainly we see a lot of physical and psychological abuse that persists over the life course, unfortunately, similar with sexual abuse, which I'll talk about in a moment, and the prevalence of that among older adults, which is pretty significant. We see a lot of financial abuse, and we think that financial abuse is really core to our phenomenon. We see it a lot co-occurring with the other violence types. There's very, very rarely a case where there's not some form of financial exploitation, whether that's someone who's living in the home without providing financial support or directly taking money. This really covers a lot of our cases. And then neglect often happens as well. And I think of neglect as really the terminal stage of elder abuse, and a lot of us in the field think about it this way. That is usually when elder abuse turns fatal, is when we're in these neglect cases. And we see all of these together in some cases. We see just a couple of them, but we can really see all of this within the VESPA team and within the phenomenon in general. Sorry, my slides are delayed. So let's talk just a little bit about how common is elder abuse, because I think it's something that we don't hear a ton about. But we know from community-based studies about 10% of older adults experience some form of mistreatment each year. When we look at nursing home residents, that number goes up to 20%. A lot of that is from other residents, as well as family members or other loved ones coming into the nursing facility. So that's not just staff on patient abuse. That can constitute a lot of different types of maltreatment. And we know that 9 in 10 of these cases involve a family member. So I think the cases that often make the news are the paid caregivers or the nursing home cases, but the vast majority of this is happening within family systems. And that's why we're so excited to partner with the Kempe Center, which is one of the hallmarks of family violence, to really get at this interesting and complicated phenomenon. Within Colorado, APS receives about 25,000 reports of elder maltreatment, self-neglect each year. About 8,000 of those are substantiated or opened. That speaks a lot to the limitations of APS. The APS can only open cases in certain situations. Patients often have to participate or want APS's involvement. And so they are rather limited in what they can do. They do wonderful things when they are involved, but just by the statute, they can only do so much. But we see quite a bit of elder abuse in Colorado. I apologize. There we go. And then this is some data that Dr. Rosen, my mentor out at Cornell, and I had worked on several years ago, along with a whole team out there, using the National Epidemiologic Injury Surveillance System data, which surveys representative ERs across the country to get at national estimates of diseases or injuries in this case. And so we looked at the assault-related injuries for anyone over 60 presenting, and there was a narrative involved as well that we analyzed. And we saw that from 2006 to 2014, there were almost 8,000 assault-related injury visits just for older adults. And that's when they reported, I'm here for an assault. When we extrapolated that out using the CDC algorithms, that represented almost 425,000 cases within the country. And 57% of those were within one of those relationships where there's an expectation of trust, which would meet our definition for elder abuse. So this is a very large problem, even though it's not seen very often. And as you can see, the type of abuse also changes a little bit within older adult. So older adult is kind of a broad category, as many geriatricians will talk about. 60 is typically the cutoff we use because that's what Older Americans Act dollars say. And that's when APS considers 60. So that's what we did for our analysis. And you can see that the altercations go down as we age, but sexual assault increase. And so we do see a fair amount of this in our populations, even though it's hard to think about and hard to identify. Oh, there's. And why, as physicians, are we so interested in this topic? So we all know abuse increases the risk of death. Elder abuse increases the risk of death threefold compared to age-matched and comorbid-matched comparisons in multiple analyses. We also know that it increases the risk of depression, physical illnesses, PTSD, other things that substantially impact quality of life. And very importantly for our patients, our families, and also for policy, and when we think about Medicaid dollars and where those are spent, it really increases the risk of someone being placed in a nursing home. Particularly, this is intertwined with financial abuse because we see maybe there were financial resources that could have kept that patient in the community and those are now gone. So I'd say a lot of our patients end up unfortunately being placed in nursing homes on Medicaid. So this has huge implications, not just for our patients, but also for policymakers and for our Medicaid dollars in the state and nationally. And then this is also significantly impactful for certain vulnerable populations. I've done a little bit of working with the LGBT community, and that community, going to a nursing home puts them at increased risk for at least psychological abuse, if not outright physical abuse from other residents and staff members who might not be as trained in that population. And also, when I think about our rural populations who might not have nursing homes in their local communities, having to be displaced at the end of life seems particularly cruel as an outcome. So this has huge implications for our patients, their families, and for our systems. And we think that elder abuse, unfortunately, is about to get worse. So we're going to see a lot more of it as the population ages, which I always say is a very good thing. Thank you, public health. We are now aging. We've gained a lot of life expectancy, but we will likely see a lot more violence, unfortunately, just as the numbers grow. And that's a big problem when we know that only one case of elder abuse comes to any kind of reporting out of 24 that are existing in the community. And this has also been well substantiated by a large community study, and this number persists in other studies as well. So we're missing this all the time. And as medical providers, we talk a little bit about gaze aversion And that's the topic for us today. And there's a lot of reasons why we don't see this. One is a lack of training. I'm almost through my residency, so almost through my medical training. And I have received very little to no formal training in elder abuse. So providers lack at training on identification and what to look for, how to ask about this, what are the injury patterns. Our field does suffer from a little bit of a lack of data, but what is out there isn't really taught very often. People don't know how to report or who to report to. That varies from state to state. People are not trained on that routinely. And then how to provide trauma-informed care. This is not something that's routinely part of medical school curriculums or other professional learning curriculums. So there's just a lot of knowledge gap there. And we know as providers, when we don't know what to do with something, we don't look for it and we don't ask because we don't want to not know what to do when we find it. And so identifying this and addressing this is very important to our field. These are also emotionally charged cases. The amount of times my co-residents go, "Ooh, that's real sad, Elizabeth. Please don't talk to me about this anymore," is almost weekly. And so, these bring up an emotional response in providers. And when you couple that with not knowing what to do, it's a recipe for people to not look and to not ask. And I think a lot of it's also a fear of making things worse for these patients. As a primary care provider, you want them to keep coming back to you, so at least you can make sure that they're doing okay. And the fear of if I report wrong information or misinformation, or then the family member gets mad that I reported, they won't bring them back to me, and that relationship is severed. And I think that is also a big piece of this. And then also just the time needed for these encounters. When a patient reports or when you have concerns, that's a long conversation that when you're in a 20-minute primary care appointment, that kind of blows your whole schedule. And then the mandatory reporting that comes along with that. I know personally, I've sat on the phone for half an hour with both APS and law enforcement trying to report. And if you're in the middle of a busy clinic day or ER shift, or even on the inpatient side, that is a lot of time that is needed to discuss these cases and to really get the patient what's needed. We all will do it in a heartbeat if we need to, but I think it is a piece of the puzzle of logistically, when you put all of this together, it's not going to be something that comes to your mind at the first thing.
So if we ended the talk here, you might draw the conclusion that elder maltreatment is a terrible problem and it's never going to be solved. But lest we leave you with that impression, we just want to bring up the fact that for kids, this problem has been solved. I mean, kids are still abused, it's still a big deal, but we've made tremendous progress. And that gives us a model to go forward. So this picture, as most people who've been on this campus know, is Henry Kemp. And Henry Kemp, back in the 1960s on this very campus, was the first physician to bring widespread attention from the medical community to the issue of child abuse. I think if you had asked doctors at that time, well, what is child abuse a big deal? They'd say, well, it's a big deal when it happens, but it probably happens, I don't know, 5 times a year in the United States. And Henry Kemp really changed the view of this to realize that it's one of the most important sources of morbidity and mortality for kids. And one of Henry's biggest innovations with his team was the idea of the multidisciplinary team. Henry recognized that the profession of medicine has an important role to play in protecting kids, but it's by no means the only player on the stage. And Elizabeth's major insight was that we needed a Henry Kemp for the field of elder abuse. And that was the genesis of VESPA. So VESPA is a collaboration between several different teams, not least is the Kempe Center, because the Kempe Center has been doing this since the 60s. And I think the field of elder abuse is really just getting started. But if it is just getting started, it got started first in Cornell with Elizabeth and her mentor, Tony Rosen, and they've partnered really closely with us to try and develop this even further. We've gotten a ton of support from a lot of people on campus, some of whom you'll see pictures of, you'll see a lot of names and organizations, but VESPA is centered in the Multidisciplinary Center on Aging, and it's funded by a Colorado State Victims of Crime grant. So what do we do? To illustrate it, I think we should get back to the case. So one of the huge advantages that we have on our campus is a world-class forensic nursing team. Right now, VESPA isn't it doesn't have the resources to be 24/7, 365, but the forensic nurses are definitely 24/7, 365, and they've been exceedingly energetic about helping us out. So for any clinician who's on the call, if you're on the university campus, your first step is like any other case of family violence to call the forensic nurses. And in this case, the forensic nurses got the first consult for Mr. R. They did a thorough exam. They helped with photo documentation. If it was needed, they could do forensic evidence collection like DNA swabs and rape kits. And they can also help with the initial reports to Adult Protective Services and law enforcement. And that's when VESPA gets involved. So we, the forensic nursing team, got in touch with us, let us know about Mr. R. And that's when the core members of the VESPA team got involved. Pictured here, you see our dual Sarah combination. Sarah Cox on the left is our social worker, and Sarah Tietz on the right is one of our elder abuse geriatricians. And so during business hours, they went by and saw Mr. R. And on their first interview, they found out that Mr. R's son is an alcoholic. He has a pretty severe alcohol use disorder. And that Mr. R sometimes misses his medication. And it got to, people started thinking that maybe Mr. R got sick because he missed his medication and ended up going to the bathroom, or to the bathtub, because he wasn't able to, clean himself up and take care of himself. And that maybe his son wasn't able to recognize this, care about this, or know what had happened because of a severe alcohol binge. But later we went back for a second interview, and Sarah Cox heard from the patient that his son actually knocks him around from time to time, and that there's a 3-year-old grandson of the patient, and the patient's also concerned that he might get knocked around by his son, bringing together this idea that violence is something that affects a whole family sometimes. So VESPA at this point can recommend medical testing. One thing I learned is that pre-albumin can be a mark of things like starvation or neglect, and we can make those sorts of recommendations. And we can really move forward with communication with the other professionals outside the medical community and within multiple medical services. So certainly in the child protection world, it's not uncommon at all to have to coordinate between neurosurgeons, orthopedic surgeons, traumatologists, intensive care unit doctors, who all have their specific area of focus, and none of those areas are about elder violence. And then we're blessed with having a seniors clinic that can help with follow-up for these issues, which are often chronic in nature and are almost never figured out in the first few hours of a stay. Our consultations frequently culminate in a multidisciplinary team meeting where we invite APS and law enforcement so that we can coordinate the care between the medical and other specialties. So in a case like this, an MDT is a chance to help APS and law enforcement understand the significance of the metabolic derangements, right? A potassium level of 7.5 may not mean a lot to someone who's a peace officer. We can help them understand how long it takes for these things to develop and what sort of signs a reasonable person might have seen if they were starting to develop, or what they might not have seen. We can estimate sometimes the age of injuries, but most importantly, we can let them know what sort of medical care is needed in the future and what sort of things the patient is going to need to be safe and healthy after they've had maltreatment. We can also estimate the likelihood of maltreatment or the likelihood that some injuries could happen by normal activities or accidents. It also helps us understand things that we can't understand from the perspective of the hospital. So like, is this guy's son responsible for him? Is he in a position of trust, or is he just living in the basement and they don't really see each other that often? Was he supposed to recognize this? Is his son living off his expenses? And again, if this MDT looks familiar to you, it really should, because for decades now, every children's hospital in the country has had something like this for a child protection team since Henry Kemp in the 1960s started this model. But to my surprise, as a child abuse specialist, we're really only the second in the country to do something like this for elders. And that's, as Elizabeth has said, it's not because elder maltreatment is less common or less important than child maltreatment. It just hasn't gotten started. So if you're on campus or if you're just curious, who do we see? Well, we see anybody who's over 70 years old with any concern for any of the types of maltreatment that Elizabeth mentioned who's an inpatient in the hospital. We also see some people who are younger than 70 if they have conditions that make them seem similar to an older person, like early onset dementia, Parkinson's disease. Rarely, I suppose someday we may see a case of progeria, but sorts of things that can make someone physiologically older if they're not chronically older. One big exception, which is based on our resources, is that we don't see cases of self-neglect, right? So if someone's 80 years old and everyone says they should really be in a nursing home, but they don't go to a nursing home and they spend their time hoarding their stuff and getting sicker and sicker, that's not really maltreatment. It's a tragedy, and we should focus on that, but that's not what VESPA does yet. For those of you who are on our campus, trying to think how you could get in touch with us if a case like this comes up, we see patients who are in the emergency department or in the hospital. We don't see patients where you've got a concern from your clinic. And the way to get in touch with us is to reach out to our forensic nurse evaluators. They'll get in touch with us and coordinate the care. And in most cases, our geriatrician, our social worker, and the forensic nurse evaluator will do a coordinated assessment that works the best for the patient. We also see patients at Denver Health, and this can be done at a clinic or a hospitalization. And the consultations there will go through the Denver Health social worker. Our elder abuse geriatrician there is Dr. Yasui, and she will work with the social work team there to provide the individualized consult that the patient needs. One of the biggest questions that we face with VESPA is the issue of capacity. And capacity, depending on the decision you're looking at, can be a very simple concept, or it can be a very nuanced and layered concept. For those of you who aren't clinicians, capacity means the ability of a patient to make their decisions for themselves, by themselves. And sometimes this is pretty straightforward. If someone's comatose, they don't have capacity to make medical decisions. But sometimes, and especially in cases of elder maltreatment, the decision itself is different. The ability of someone to make a decision really depends on what decision they're making, right? So someone could certainly understand who they want to be their surrogate or who they want to make decisions for them. That's my daughter. I trust her with anything, but not necessarily able to make some decisions like, do I want neurosurgery? And capacity can change over time, especially as we correct some of those metabolic derangements or some of the intoxicants metabolized through the body. So one thing we were finding when we created VESPA is that a patient came into the hospital on day one and the medical team said, okay, this person doesn't have capacity. How are we going to get them to a stable placement? And 30 days later, that was still the assessment. And the patient had improved quite a bit and may have had capacity at that point, but no one had reevaluated that decision. And that probably, I think, is the biggest question that comes to us from APS and law enforcement is one-stop shopping about who to talk to and a more nuanced understanding of what capacity someone may have. We also do outpatient follow-up. We can help people get connected to a safe primary care home. Often that's the seniors clinic or Dr. Yusui's clinic at Denver Health. We can help coordinate some follow-up and do some ongoing social support. And definitely we can continue our communication with APS, law enforcement, victims resources, and other people outside the medical community who help make sure the patient has the best outcome.
Okay, so thank you, Dan, for summarizing that so well. And part of our team's goal is to also improve the research in this area. As Dr. Lindberg had mentioned, we are about 40 years behind other fields of violence in terms of our research. So there's a lot of room to grow with this. And we hope that this team is going to serve to provide a lot of patients that we can then study. So we are building a registry in conjunction with Cornell to track this. And part of our goal also is that our research has been really limited by the types of cases we can get. And so research that I have worked on and others have worked on in the field often use law enforcement databases or APS databases. And those are really limited and limited into the types of people who end up interacting with those resources, and the healthcare system sees just a wider swath of the population. So we're hoping that not only can we get better, more in-depth data, but we can also get a little bit more equitable data to look at this more complicated phenomenon. And so we mentioned a couple of times now, we're very close with our partners at Cornell. So they were able to actually come out during one of the kind of lulls-ish in COVID recently and meet with us all. We are working super closely. We share note templates, we share protocols. If we have challenging cases, we discuss them together. And we also are working on a REDCap database. We share the same data dictionary so we can collect data that can then later be merged for research purposes, which we think will really help advance our field forward and can also be used if any other new teams want to start in the country, which we hope they will. And what we're focusing on now is really a lot of defining. So we are really working on what do we really need to track for these cases. Older adults are different than other victims of family violence. There's different things we need to track. There's different levels of data we need. For example, making sure we're getting the right dementia diagnosis is something that comes up a lot. Like Dan had mentioned, capacity is so crucial to our cases, and making sure we have that defined in a really robust way. Defining just things that we want to track routinely. We also want to make sure that we're defining outcomes that are pertinent to a multitude of people. So we want to make sure, we as providers are always interested in morbidity and mortality, things like that. But also the cost of this program, the cost of unidentified elder abuse is very important for health systems and policymakers. And then most importantly, we want to look at outcomes that are important for patients and families. And I think that's something that we've struggled with as a field, often because our patients do have some level of cognitive impairment, and figuring out a way to engage them meaningfully in that interaction can be a little bit more challenging. And so I want to talk a little bit about a methodology that we're starting to use now called goal attainment scaling. And this comes out of the rehab literature, actually, like physical therapy and occupational therapy, and was applied to elder abuse first by a professor of social work up in Toronto, David Burns, who worked with Maine APS to implement this with their patients, or sorry, their clients. And we are doing something similar here. And so really goal attainment scaling, the whole concept is to sit down with your patient and identify what are their goals and then how do we reach them, and then a little bit more objectively measure that. And so I pulled an example here because I think this one's useful for our field. So often the abuser lives in the home with the patient, and that is where the abuse is occurring. And the patient just says, I just would like them out of my house. We hear this a lot. And so we would expect that over 6 months, a year, working with APS, working with law enforcement, we can get the perpetrator out of the home, get an order of protection in place. Most patients won't enforce it because it is a loved one, like their adult child. They don't want them to get into trouble. So that's kind of our expected outcome. So that would be a score 0 at the end of the year. A better than expected outcome would be that they are evicted, there's a final order of protection, and the perpetrator is not coming over to the house anymore. Maybe the patient is able to see them in a non-abusing family member setting or a safer setting, but they're not coming over anymore. So that would be an ideal outcome. And the not ideal outcome, or the -2 outcome, would be there's no order of protection, they're still living in the home, everything is going on as normal, no engagement. And I think this is very interesting from a lot of different ways. I think some of the pure methodologists who trained me during my MPH wouldn't love this, but I really like that this is both a tool, a therapeutic relationship building tool. It smells a lot like motivational interviewing to me, where we can really engage patients in their care, as well as a way to more objectively measure some of these outcomes that are a little bit more qualitative in nature when we're looking at the impact of these programs. So I think this adds a lot of promise for our field. Both our team and Cornell's team are going to start using this with our patients. And what we're also hoping to do is really help identify what do they want, and what do they want from a healthcare setting in particular, because I think that is really missing from the literature, and this is a great way to get at that. By using it with our patients. We will use this with any patient who can participate, and then also with non-abusing loved ones if a patient is unable to participate or if they're just very involved in the case. So more to come here, but I think it's a really exciting methodology to pursue.
The other big broad research agenda that we have, it's somewhat ambitious, and this is a long-term goal of ours, is to reframe the whole conversation about family violence from the historical approach that we've taken. So I'm going to do a little bit of a history trip. More than 100 years before Henry Kemp got involved in child abuse, Henry Berg was the US ambassador to Russia in 1866. And he was going down the street doing his ambassador thing when he saw someone savagely beating a horse. He dropped what he was doing. He stopped the guy from beating the horse, stopped being the ambassador to Russia, came home and founded the ASPCA. He did that because he cared about animals. Nearly 100 years later, Henry Kemp comes along and does what I talked to you about and forming MDTs. And he was a pediatrician. He was a pediatric virologist, but he was a pediatrician. And he did this because he cared about kids. And so he studied kids. Intimate partner violence got some attention during the Temperance Movement, but that faded with the Temperance Movement. And the first shelters for IPV grew out of the Feminist Movement in the 1970s. And both of these movements cared about women. And we're starting elder maltreatment teams because we care about elders. So it's natural that the passion for these movements come from people who care about the people who are hurt by this kinds of maltreatment. And it's natural that those of us who start these movements know a little bit about the victims. But Elizabeth and I think that that's really looking at it the wrong way, because you're not going to solve the problem just by studying the kids or the animals or the women or the elders. You have to study, we believe, you have to study the cross-cutting components that lead to the abuse in the first place. Now, honestly, the one movement that we're talking about that may have done this was actually the Temperance Movement. Now, it didn't get any legs because temperance and prohibition was something of an abject failure. But we think that there needs to be a little bit more of that movement that addresses some of these factors, like maybe untreated mental illness or untreated substance use disorder, or just violent personalities, things that affect a household all at once rather than affecting one person. One of my colleagues says, if you're someone who believes that violence is a tool that you can use to solve problems, I'm a little suspicious that you're only going to use that tool to solve some problems. You're probably going to use that tool for a lot of your problems. And there's some research out there that demonstrates this pretty intuitive phenomenon, right? So in my own work, when you look at kids who are sharing the home with an abused kid, about 12% of them, of young ones, will have fractures that no one knew about, even if they don't have injuries. And in kids old enough to be interviewed, 30% of them are able to report abuse in themselves or in their siblings. And there are other studies that look at the co-occurrence of child abuse or intimate partner violence and animal abuse. People haven't done a lot of work looking at elder abuse, and that's certainly something we're going to do. And data is really limited, so it's one of our first jobs. But while our first goal is to really describe the overlap, ultimately, we'd really like to address this overlap and try and solve the issue of violence itself rather than looking at one victim or another separately.
Thank you. So our team, we're very excited. We're growing. We just finished our first full calendar year as the VESPA on campus. We're looking to expand our services. Soon we will be providing consultations to other outside hospitals. And in the coming years, we hope to expand to more outpatient services as well. We're excited to start our research in a more robust way, helping to define these outcomes. And ultimately, we want to work towards identifying the risks that cause this in the first place, like Dan was just mentioning, risks at the patient, the caregiver, the family level, or other sentinel events, particularly in aging, so we can actually get at harm reduction and prevention. And hopefully in the future, we also will identify the best and patient-centered treatment options for this complicated phenomenon. So thank you all so much for having us. Thank you to everyone on our campus and across the country who's been very supportive of our team's development. And we look forward to answering your questions. Here's our contact information as well, if that's helpful.
Thank you both so much. Lots of things to think about. I'm so proud to work on a campus where this is developed. I had nothing to do with its development, but I think it's really such a great service for our patients, and community, but also really leading the way in this space. So we have some time for a Q&A, so please go ahead and put questions into the Q&A box or comments. I have a couple questions to start us off with. First one, maybe an easier one. I think we have some participants from some different health systems on the line, which is great. Dr. Blumen, you mentioned that you're hoping at some point to expand to offer consultations to other places. In the meantime, what would your advice be to places who want to do even just a little bit more, dip their toe in the water? Sort of what are some easy things for places to do?
Yeah, there are a lot of really great resources out there through the National Center on Elder Abuse, particularly the National Center on Abuse in Later Life through the Office of Violence Against Women, to just get some more training for providers. I think just talking about this, knowing it exists, knowing what to look for. There is data on injury patterns out there. There are other trainings available. I think that's a great place to start. And then just outreaching your local APS and law enforcement agencies that you interact with, and just having an introduction and a face to the name, I think is huge and can have a lot to the coordination for these patients.
Can I add two things? The first is, I think for any hospital to begin to address it, the first thing is to identify a champion. There is not 15 chapters on elder abuse yet. Elizabeth will write them all someday, but she hasn't done it yet. And right now, the only reason we know more about this than most people is because we think about it a lot and because we see all the cases. And I think that if a hospital wanted to get serious about it, the first thing they would do is just try and sort the cases to one person. The second thing is that we really hope to have VESPA's consultation resources available to other hospitals in the state of Colorado really in the next few months. It was part of the grant that we got from VOCA. Now, we haven't set it up yet, and there's a lot of hurdles that we need to get over, but I know that we will. And so if you're saying, hey, I'd like to be on the list as soon as you know that you're doing this, reach out to one of these email addresses here and let us know. And as soon as we are up and running, we have Jody Waterhouse has joined us. Her mission is to help us with the outreach and communicate with other people who might be able to use that service. So please do let us know.
Great, thanks. I'm going to take my moderator privilege and ask one more question before we get, there's one question that's come in from Sarah Brandspiegel. Dan, I think it's fascinating, this sort of thinking about violence within a family or within a home as a issue. I remember actually you years ago coming into my office very excited about something in that space. And I think it really is an interesting way to think about it. What, if any, coordination is there between sort of the government agencies that do this? So CPS and APS, animal welfare, is there any sharing of records or discussion amongst those agencies? So if there's an animal cruelty report that comes in, does anything happen in terms of thinking about the people in the household or vice versa?
So there's a huge dollop of I don't know about this because I work in the medical space. There's also a huge dollop of I bet it's different for every single county in every single place. One person who really influenced my thinking about this is, I'm trying to remember her new last name. She used to be Tara Hofer. She just got married, and I can't believe I'm blanking on this. She should be set up for canonization, even though she's not Catholic. She spends her days taking care of abused kids, and her nights, her off time, she runs a no-kill animal shelter for medically complicated animals. And she recognized that, you know, she's got a few cases of someone calling saying, I need you to take my dog. My boyfriend says he's going to kill it. And then they show up with a toddler on their hip, right? And so her two worlds collide at that point. And she has really done a lot of work with animal protection, whose badges say public safety officer. And they really internalize that to say, whenever we walk into a home where there's animal cruelty, we should start to look and see, are there kids in that home? And this is something that still has a lot of work to do. That's the formal part. Informally, I'll just tell you that the people who work in adult protective services and animal protection, child protective services, they get it. And they're here to work with safety. And there's never been anyone where we've said, hey, we really think that we should approach violence from a household perspective that doesn't go, oh my gosh, of course, I 1,000,000% agree. And, we haven't figured out a way to approach every single family from every single direction. Our first question is just, well, how often are abused elders living with kids or animals or spouses that are being abused? That's our first step. But when a case comes up, people are very enthusiastic to work together.
Thank you. So Dr. Blumen, maybe over to you for this next question. So Sarah Brandspiegel asked a question about sort of thinking about social policy levers. So how do you think about the social policy responsibility to protect older adults and how that interrelates with family or individual roles? And are there policy levers that would ensure older adults are safer? Any thoughts on that?
Yeah, this is brings me back to a lot of my public health days, which is wonderful. Yeah, I think that, aging is a wonderful and fascinating field because it has changed so much. So when we think about how our aging infrastructure was built, all of it was built in the 1960s, where the vast majority of women were not working in the home, but provided the vast majority of informal care for older adults. And our system's still built for that. And so I think when we think about this, it's very nuanced, it's very complicated of how are we going to deal with this extra 20 years of life expectancy that we've gained as a population. And I think elder abuse plays into all of that, into the financial implications and the financial resources that a lot of older adults have within the family systems, and then the caregiving needs and the caregiving burdens, I think, are complicated. And I hope people far smarter than me are also working on this, because it's very complicated. I know that I have great hope also. While there's intergenerational violence, I think intergenerational programs are also going to be one of the things that leads us out of all of these, and really capitalizing on the positive sides of having an intergenerational family. I know even in our own elder abuse cases, a lot of it is grandparents intervening in child abuse, which is a beautiful thing. And I think, capitalizing on those positive relationships is going to be something to going forward. I hope that answered that question. I think it probably just posed more questions. Yeah, I think it's an interesting part of this dynamic and something that our world is dealing with for the first time. And so lots of room.
Yeah, thank you. I feel like we can't have a webinar these days without this question. Any thoughts or reflections on what the pandemic has done in this space?
Oh.
Yeah.
Yeah. So Tony, who's like my big brother mentor, actually wrote a paper with a couple of people about this. APS could not go into the home during COVID for a very long time. We know that violence across the board increased during COVID. I think we have a lot of this and a lot of things that were not identified. I think we're going to see the sequela of that for many years to come, unfortunately. We know that there was also a huge amount of social isolation, particularly for our older adults who are the more medically frail, but that also puts them at increased risk for abuse. Social isolation was already the #1 risk factor for abuse, and that just went through the roof. So I don't know that we know exactly how far it's permeated yet, but we're expecting it to be pretty pronounced.
Is there any hope of using sort of tele visits or newer technologies for some of those home visits or investigations? I realize this is outside of what you guys do now, but now I'm just curious.
Yeah, go ahead, Dan.
Well, I smile because, I can't get my mom to figure out how to download a song on iTunes. So I think telehealth might be uniquely hard in this population. I think that the tricky part is that a lot of times elders need help with setting up the novel stuff, and the people who are helping them may be the people who are hurting them. And so I'm super optimistic about CPS doing, or pediatricians doing telehealth visits for kids. Maybe super optimistic is a little over the top, but I'm less optimistic for elders. But we have to look at everything. I think this is going to be more complicated than just it turned things up, or it wasn't. When we've looked at this for child abuse, it's been really complicated. Certainly there's the whole, well, they're not going to school, so we're not seeing it, so it might be a little worse. But some of the most severe forms of child abuse have pretty good signals that they may have gone down a little bit as intimate partner violence went up. And I don't have enough data to say this for sure, but one hypothesis I'm interested in is that if more moms are stuck at home, they're getting in front of the violence before their kids. But I think it's really complicated. There's a lot of studies that come up with very different results.
One note on the telemedicine piece, I think direct telemedicine, maybe not as much for this population, but provider to provider, I think there's a lot of room there, because we have not developed the systems that child abuse has, where, you know, my best friend practices in Ray, Colorado on the Kansas border. It would be wonderful if at some point she could call us up and say, I have someone in my ER, this is what's going on, what do I do? And so we are looking at building those kinds of networks for elder maltreatment. The problem right now is there's like maybe 15 physicians in the country that actually do this routinely. And so we are lacking in manpower at the moment.
Yeah, that makes sense. Another question, I have often asked this of you, but I want to ask it in public too, because others may have the same question. The overlap between domestic violence or partner violence and elder abuse, you know, what happens when a couple turns 70, for example, or how do you think about that overlap or sort that out?
Yeah. So a lot of elder abuse is what we call domestic violence grown old. And I think those are the victims that come to my clinics and say, I need to talk to you about something, and it's been going on forever. And it is a different dynamic. I think the National Center on Abuse in Later Life was out of the domestic violence movement. They've done a lot of work in this area. I think it's a very different trauma typology almost when you're looking at that. You also now have adult children who often witnessed violence their whole childhoods and now are caring for these people. And that becomes a very interesting and difficult dynamic that we need to help support better. But we see a lot of domestic violence grown old. It's often not a new phenomenon. And how do you navigate that now that both the abuser and victim are frail and that dynamic has changed? It's very interesting, but we see it in our clinic all the time.
Oh, wonderful. Thank you. We're almost at time, so I would love to just know anything else you both want to share with us, things that didn't come up or you didn't mention, or other ideas, words of wisdom.
I would just say that if anyone is at the early part of their research career and cares about injury prevention and is looking for a field that is fertile in terms of big questions that need to be asked, huge impact to be had, and frankly, funding resources that are available. I mean, people care about elders. Elders vote. And I think it's pretty intuitive that this has been under-researched for a while. We've got more than we can handle in terms of all those different things. We don't have more funding than we can handle. We could handle some. But if you're interested in joining our team, please do reach out. I think that we have a lot of room to grow.
Great.
Yeah, that was my main thing as well. We're always happy to collaborate. Always happy to be called if there's clinical questions. We'd rather be called too much than not enough. And then I also do want to share, Dr. Betts, you did have some part in this because you introduced Dr. Lindbergh and I many years ago.
Oh, I did. I'm going to take all the credit then. No.
Yeah, I think two things to counteract is one, that Emmy didn't help build this, which is not right. And then two is that Elizabeth doesn't have any training. I think she really meant to emphasize the formal training part of it. She probably knows more about this than almost anyone in the country.
Yeah. Well, thank you both. I think this really just highlights the injury and violence community, maybe small, but is mighty and growing. And there are lots of opportunities for this kinds of translational work that directly affects patients and communities. But also good science to be done. So thank you both for the work you are doing. Thank you to everyone for joining us. We will send out a link to this so you can share widely or watch it again. And please do reach out to our speakers. I know them both, and I know that they both really mean it when they say they want to hear from you. Thank you all. Be safe, be well. We'll see you next month.